Type 2 diabetes prevalence in Auckland's Pacific communities is not a statistical artifact. It reflects a food environment, housing quality, and economic stress profile that makes chronic disease physiologically probable. The clinical response, insulin, dialysis, amputation, treats the consequence while the cause persists. Pacific community health workers, culturally safe screening, and community-based management represent a different model, meeting people in their communities before they need hospital care. Car-dependent Auckland constrains physical activity. The density of fast food near schools in South and West Auckland is not accidental. It is an economically rational response to the concentration of low-income households in those areas. Planning tools that restrict unhealthy food environments are slow and contested, but address the chronic disease driver that clinical medicine cannot reach. No other period of human development is as consequential or as cost-effective to invest in. The neurological architecture laid down between conception and age 2 determines much of the cognitive, emotional, and physical health trajectory that follows. In Auckland's most deprived suburbs, this window is characterized by maternal stress from housing insecurity, nutritional deficiency, and family violence, determinants that midwifery and clinical care can document, but cannot resolve without housing and income policy responding in parallel. A pregnant woman in Manger who cannot find an LMC because local midwives are at capacity or have left for more sustainable caseloads elsewhere is not accessing a health system failure. She is accessing the predictable consequence of midwifery underpayment in a high-complexity environment. The workforce gap is addressable with pay structure changes that are known and priced. The political delay is a choice. New Zealand's mental health system is rationed to severe and enduring illness by resource constraint. Moderate need presentations are declined or placed on wait lists that exceed the window of effective early intervention. The consequence is that mild presentations that could be resolved with a short course of community treatment escalate to acute crises requiring inpatient admission at far greater cost. The system is spending on the wrong end of the treatment cascade. The rise in youth ED mental health presentations since 2018 is concentrated in self-harm and suicidal ideation. CAMS is not resourced to see these young people within a clinically meaningful timeframe. Families can face long waits for a 15-year-old in acute distress. This is not a borderline resource allocation problem, it is a clinical safety issue. Amenable mortality measures deaths that should not have happened with timely, effective care. When residents of Auckland's high-deprivation communities die at substantially elevated rates from preventable conditions, a burden carried disproportionately by Maori and Pacific families concentrated in those neighbourhoods, the health system is not delivering on its equity mandate. This gap has persisted through multiple health system reforms, suggesting it is not primarily a structural organisation problem, but a resourcing and access problem concentrated in specific geographies. Every avoidable ED presentation represents a primary care access failure. Middlemore's overcrowding is partly driven by patients who could have been seen by a GP 3 days earlier, but could not afford the co-payment. Fixing primary care access is cheaper and faster than building new hospital beds, but requires a sustained co-payment subsidy that is fiscally contested.